So if we start off with our HLA phenotyping scheme, which is scheme 1A, the purpose of this scheme is to assess participants' ability to use serological and supplementary methods to correctly identify HLA phenotypes. So we ask participants to report their results at the split specificity level. And this is because we acknowledge that people don't use serological typing techniques in isolation anymore. So if you do get a result that, for example, is a B40, we would expect you to use molecular techniques to then decide whether it was a B60 or a B61. Consensus is agreed by at least 75% of of laboratories agreeing each specificity. And satisfactory performance is getting 9 or more complete HLA phenotypes in agreement with consensus during the distribution year. And we send out 10 samples over 2 distributions. So apologies if you can't see me. My camera is on and I can see myself, but for some reason it doesn't seem to work in. But as long as you can hear me, I think that's the most important thing. So as we review the scheme 1A performance for this year, 2020, we can see that there's been a decrease in the number of labs that are considered unacceptable performers. There was 3 labs in total, one of which was from the UK and Ireland, bringing the percent unsatisfactory performance to 8.8%, which is a decrease on the past 2 years. So that's going in the right direction. So when we look in a bit more detail about the errors we've seen in our phenotyping scheme, there was a total of 14 incorrect HLA types reported by 6 labs. 5 of these reports contained broad, not split specificity. And as I said earlier, we specify for this scheme that you need to report to the split specificity level. 5 reports where the specificity was just completely incorrect. 2 reports that had used molecular nomenclature instead of serological nomenclature, and 2 reports that involved a sample mix-up. So of the 3 labs that had unsatisfactory performance, all 3 of them responded and completed our Kappa form, which was fantastic to see. The majority of the errors were post-analytical, in that the errors were in terms of reporting to us rather than the test. Although one lab did say they identified an issue that they had a low B cell count, which wasn't picked up in their routine checks. So that was why they reported an incorrect type. The next scheme then is our DNA typing at the first field resolution scheme. So this is the scheme where we check low resolution or first field HLA typing. Again, we require 75% agreement on each allele. However, we will use a reference result if consensus isn't reached. And we always use a reference result for DP assessment. So DP assessment is a bit different in this scheme because we allow strings of alleles to be reported. And this is because a first field DP result doesn't really make much sense. So we allow second field reports and strings of alleles in this scheme. And as long as the reference DP allele is included in the string that you report, we consider that to be an acceptable result. And again, you need to get 9 or more full types in agreement with the consensus each year. So when we look at the performance for 2020-21, we can see there were 8 labs with unsatisfactory performance, none from the UK and Ireland, which is an increase on the percentage unsatisfactory performance compared to last year, but is reduced compared to the previous 3 years. When we look at the reasons why these errors occurred, we can see that there were 27 incorrect HLA types overall, reported by 18 different labs, 5 of which involved labs from the UK and Ireland. The graph at the bottom just shows you where the errors were made, which loci, and in total there were 69 errors made at different alleles. So the errors were due to 10 incorrect assignments. So labs just reported the incorrect type. 8 incorrect uses of nomenclature, 6 missed null alleles, and these all involved a DRB4 null. There was 2 ambiguous assignments where a lab reported it could be a B7 or a B42. And there was also 1 missed assignment where a lab reported a homozygous result when it was actually heterozygous. The rate of response of the kappa for this scheme was quite disappointing. We only received 3 out of 8 responses. And these responses are really quite critical for us to be able to help labs make sure they understand the reason why the result was incorrect. As we explained this morning, a big ethos of ours is to be educational and offer support to laboratories. And we can't do that if you do not respond when we send you a kappa form. So of the kappas we did receive, we didn't find any analytical errors, so that was really encouraging. But unfortunately, there was a number of errors that included reporting to NECAS. And most laboratories said it's because EQA reporting procedures are different to their clinical samples. We are aware that more and more laboratories are going to automated electronic reporting, and NECAS reporting involves manual entry of results and step checks, check steps, which is different. So we would encourage any labs that have a different process for EQA reporting to make sure they've got specific procedures in place and check steps to make sure the results that are being transcribed are correct. The lab that reported the ambiguous B7 and B42 also acknowledged that they're aware of this limitation of their kit, but they only use the results for disease association testing, so they're quite happy that that's not an issue for them. So related to scheme 4A1 is our 4A1I scheme, which is the interpretive element of this scheme. So labs who participate in scheme 4A1, we offer them the opportunity to register for 4A1I. And this is where they can interpret the genotype obtained from typing of the samples into a phenotype. We use a consensus, but we will use a reference result for assessment if required. And again, you need 9 or more out of the 10 samples to be correct over the year. So we did have 6 labs with unsatisfactory performance, 2 of which were based in the UK and Ireland, which is a decrease from last year, but in keeping with sort of the overall trend we're seeing with this scheme. So when we look at the reasons for the errors, overall there were 23 incorrect HLA types, which is about 5%, reported by 15 labs, 7 of which were in the UK and Ireland. We had 12 reports that use a wrong nomenclature, so using, again, mainly molecular nomenclature instead of the phenotype. We had 8 reports just where the wrong type was entered, which is interesting because these labs had all had the correct report in the 4A1, so they had the correct type. They just did an additional transcription error for the scheme 4A1I. We had 2 reports where the incorrect broad or split was used, and also 1 ambiguous assignment where a lab couldn't say if it was a DQ7 or a DQ8. From the 6 kappas that we sent out for this scheme, we received 4 responses, and most of them were around the fact that, again, EQA reporting procedures are different to their routine clinical samples, and a lot of them were put down to transcription errors. So again, just highlighting that if you do have manual processes for reporting EQA that are different to your routine reporting, even more reason to take care. I imagine most laboratories would rely on a manual reporting in an event of an IT system failure so that services could continue. So they are really important skills to have, that results can be manually entered and checked by members of staff. If we move on now to our higher resolution HLA typing scheme, this is scheme 4A2, typing to the 2nd or 3rd field resolution. So labs can register for either assessment at the 2nd or 3rd field in this scheme. and we use a 75% consensus, but use a reference result if that consensus isn't met. And we need 9 or more full types to be correct for satisfactory performance in this scheme. So in 2021, we had 45 participants registered for second field assessment and 19 registered for third field. Overall, there were 7 labs with unsatisfactory performance, which is a decrease from the past 2 years. So I just wanted to make an important point about the purpose of this scheme. So if you register for assessment at the second field resolution, you do have to resolve all ambiguities resulting from polymorphisms located within exon 2 and 3 for class 1 or exon 2 for class 2. And we still get some labs that do unfortunately report alleles that should have been excluded, and they get penalised for this. For third field resolution, we require no ambiguities to be reported. So participants must be able to sequence all exons. So for example, there's an example there which would be considered as unacceptable because ambiguities in exon 4 weren't resolved. So our plea is, if you cannot unambiguously assign at the third field, please only register for the second field resolution. If you still do report some to the third field, you can mix and match. So for example, you could register for class 1 third field and class 2 second field, that's fine. If you want to be able to perform some manual assessment of the third field, we would very much encourage this. You can download all the results from the website, do a short report of your own third field types with ambiguities in. And if you write that up and show that to, for example, inspectors, that should be seen fine as something that you're doing yourself to check the quality of your results. Unfortunately, there's no other way. We've discussed this quite a few times in steering committee, but we can't find another way at the moment to resolve this issue and allow certain ambiguities, because all the different NGS kits on the market have different sequencing capabilities. They cover different exons. So at the minute, we've had to draw a hard line and just say no ambiguities at the third field. Results of the fourth field can also be reported, but we don't currently assess them. So when we look at the errors at the second field, you can see there was 14 incorrect HLA types reported by 10 labs. The majority, again, due to reporting alleles in strings that should have been resolved. 4 reports where the allele was just incorrect. So for example, one lab thought they'd found a B3768 allele, where it was clearly a B3701. We had 3 reports that were incorrect in the first field, and 2 reports that were homozygous when actually the sample was heterozygous. So again, the CAPA responses from these were really around training issues of staff reporting results and making sure that they report correctly, and interpretation errors. When we look at the third field errors, there was 8 incorrect HLA types reported by 4 laboratories. 5, again, as I just said, this scheme for third field, we don't accept any ambiguities, but we did have a number of labs reporting unresolved ambiguities, so they were penalised in this scheme. We had some reports that second field only, and then also a report of an incorrect allele. The CAPA responses were quite varied, but the lab that had the issue with the DRB4 allele did comment that it was a kit issue and the manufacturers were aware of it. The rest of the errors were due to interpretation errors, and the root cause for the lab that reported ambiguities was put down to a registration error, and they've subsequently registered for the second field resolution. So it'll stop them having the same reports next year. The next scheme is our KIA genotyping scheme. This is scheme 9. So this scheme assesses participants' ability to correctly determine the presence or absence of specific KIA genes. We use a 75% consensus and a reference type if consensus isn't reached. And you need 9 or more full key genotypes in agreement for acceptable performance. So again, this is quite a flexible scheme. Participants can register for any of the key genes that they type for in their laboratory. They can also report other key polymorphisms they might detect or test for, as well as they can report alleles as well if they type to that level of detail. We also encourage participants in this scheme to report whether they think it's an A or B haplotype. This isn't assessed in any way, but it's just for participant information. So fantastic to see this year, there was absolutely no errors and no laboratories that had unsatisfactory performance. So this is the first scheme we've seen so far that has had no errors, so that's great. So our HPA genotyping scheme, or scheme 10, assesses participants' ability to correctly determine HPA polymorphisms. We use a consensus, but a reference type if that is not met, and you need 9 or more full HPA types for satisfactory scheme performance. Again, another fairly flexible scheme in that participants can register for any of the following HPA 1, 2, 3, 4, 5, 6, and 15. We also allow participants to report other ones if they type locally, for example, HPA 9. There were 4 errors in this scheme last year, but none of them resulted in unsatisfactory performance. So that was really good again. We did have a look at the errors to see if there's any trends or potential kit issues. But as you can see, the errors by the 4 labs were all involved different HPAs, and they all use a variety of different techniques. So there was no clear trend there. And as Amy showed earlier, this is something that we do in a lot of the schemes. When we get more than a couple of unsatisfactory performers, we look and try and identify if there's any potential kit issues or any specific issues with a certain aspect of that scheme that could be causing the unsatisfactory performance. If we move on now to our disease association and pharmacogenetic schemes, I'll start with HLA B27 or scheme 1B. So this scheme, we ask participants to be able to report a positive or negative for each sample, whether it's B27 positive or negative. We use a consensus level again, but a reference type also used if consensus is not met. For all our disease schemes, you have to make all samples have to be reported correctly for satisfactory performance. So we had 12 labs that unfortunately didn't meet the satisfactory criteria for scheme 1B, 2 of which were from the UK and Ireland. And this is increased from last year. So this table just shows a breakdown of the errors and where they occurred, and then the lab identified cause. So we distributed in total 5 samples that were HLA B27 positive, so an equal mix of positive and negative samples. In total, there were 14 errors. We had 9 false negatives, 3 false positives, and 1 laboratory that didn't return any results. So that's why they were penalised. Interestingly, 7 out of the 14 errors involved a molecular technique. Historically, most of the errors in scheme 1B have been due to labs that use serological methods. So for example, flow cytometry and issues with the monoclonal antibodies perhaps being used or the way they're interpreted. But we have seen in the last few years an increase in errors with labs using molecular techniques. So that's something just we'll keep an eye on over the next few years, I think. Unfortunately, we did have 2 sample mix-ups, and then the other sort of root cause analysis the labs provided for us were down to transcription errors and a variety of other random errors. So the next scheme is our HFE typing scheme, or scheme 5A. this scheme's historically always sat with us because of obviously the close links originally thought to be with HLA A2 in particular. So it's always stayed under the H&I bracket. So in this scheme, we're looking at participants' ability to correctly determine HFE mutations. And there's 3 particular mutations that we assess on: the H63D, C282Y, and S65C. Although if labs are testing for others, they can report them for information. We use a 75% consensus like most of our schemes, but we do use a reference as well. And all reports have to be correct for satisfactory scheme performance. So unfortunately, we did have one laboratory this year that was unsatisfactory, and that was from the UK and Ireland. But generally, the number of labs that fail this scheme are quite low. But we've only had 1 year in the last 5 years where there was no errors at all. The lab that had unsatisfactory performance did respond to the CAPA, and they put it down to human error. They said there was cross-contamination of the sample during the testing procedures. So related to Scheme 5A is Scheme 5B, and this is our only assessed interpretive scheme. So there's no samples associated with this scheme. Instead, we assess the laboratory's clinical reports. So we ask labs to report in an identical format that they would report clinically. And for this scheme, we're very grateful we've got an expert group of advisors, 5B advisors, who help set the scenarios that we send out, and also agree what the reports should include. They then manually review all the reports that come in and award penalty points if they don't think the criteria that they're expected to cover is included in the report. So for this scheme, slightly different to the rest of our schemes, but you need to have less than 50% of available penalty points to be considered acceptable. So this year we had one lab with unsatisfactory performance, which wasn't from the UK or Ireland, which is decreased on last year where we had quite a high number, but generally the majority of labs do very well in this scheme. So as you can see, for all 4 scenarios, there was a maximum 24 penalty points available. And actually the majority of labs got 0 or very few penalty points. There's just the one lab that happened to get 16.5 penalty points that was considered an unsatisfactory performer. The reason for this particular lab, they have been participating for a few years in our scheme, but I think they're limited with the format of the report they can produce, and the assessors do not feel the report is very clear or concise or very conducive to providing the clinical advice that's needed in the report. So unfortunately, they always score quite badly on certain aspects. We have sent this lab examples of good reports, anonymised good reports for them to have a look at, but so far they've not been able to change their report template. So moving on now to our sort of pharmacogenetic scheme. So this is our B57 typing for drug hypersensitivity scheme. So as many of you will be aware, before HIV positive patients are treated with abacavir, most of them will be sent for a HLA B5701 type due to the adverse drug hypersensitivity reactions that can occur in B5701 positive patients. We use a 75% consensus level, but also use a reference if that does not met. But for many of our molecular typing schemes, we don't very often get to use a reference result. There's always really good agreement on the consensus. And again, you need 10 samples correct for satisfactory scheme performance. So unfortunately this year we did have 2 labs with unacceptable performance. We distributed 6 samples that would be B5701 positive, the remainder being negative. So this is an increase from last year where we had no errors made. When we've spoken to the labs that only one of the labs, responded to our response to our CAPA form, and they put the issue down to human error and a sample mix-up. So this is our HLA genotyping for celiac and other HLA-associated diseases scheme, Scheme 8. Again, this scheme is run slightly different to the remainder of our schemes, but it's basically aimed at laboratories that do disease association testing. And we cover several diseases such as celiac disease, narcolepsy, diabetes, rheumatoid arthritis, Behçet's, for example. So we asked labs to give us a report, to report a result in an identical format that they would use clinically. We then use a reference HLA result to assess whether that result is correct or not. Satisfactory performance is making 10 samples in agreement with the reference result each year. We also allow labs for the scheme to report interpretive comments, especially for the celiac disease scheme, but at the minute those aren't formally assessed. This scheme has the worst performance out of all of our schemes, and this year, unfortunately, the number has gone up again. We've actually had 17 labs with unsatisfactory performance, 5 of which was from the UK and Ireland. We had a very good response rate to our CAPAs, so 13 out of the 17 labs responded. And again, the majority of the errors we see in Scheme 8 are not due to testing errors, but sort of post-analytical errors, with the exception of the labelling error and sample mix-up. A lot of the errors seem to be, so the majority of labs that take part in this scheme are not H&I specific labs, because often they're covered by Scheme 4A2 or Scheme 4A1, our HLA typing schemes. So we find quite a few labs that participate in the scheme maybe don't understand HLA nomenclature and don't understand the different risk levels associated with celiac disease, for example. So we see a lot of these transcription errors, kit reporting errors, and other nomenclature reporting errors that cause the performance in this scheme to be quite poor. So this is a breakdown of the schemes that we cover in Scheme 8, of the diseases, we cover in Scheme 8, and the HLA association that we're interested in. So by far the majority of participants are obviously testing for celiac disease, but that also had the highest number of laboratories that had unacceptable performance. There's also 3 labs that had unacceptable performance for narcolepsy testing, and they were also unacceptable for celiac disease as well. So I just wanted to spend a few minutes going through some of the typical errors that we're seeing in this scheme. The first one is that a lot of laboratories seem to report the sample as being negative for DQ2, even though the DQ 2.2 heterodimer is positive, is present in the sample. So that heterodimer is made up of DQB102 and DQA102. And although it is associated with less frequency with celiac disease than, for example, the DQ 2.5 or DQ8 heterodimers, there is a quite well-established association in the literature. Therefore, these labs could be excluding celiac disease incorrectly on their clinical reports. The second example is one where the lab has reported a false DQ2 positive. Again, this is something we see quite often. So in this sample, the sample is positive for DQA 0501, which can be associated with DQ2. But in this case, it's associated with DQB 0301 or DQ7. But labs see that the DQA alpha part is present and report the sample as DQ2 positive. The third example there is just one where we get some weird and wonderful reports that don't really make much sense to us anyway. So for example, half DQ2 positive, I'm not sure how useful that is to a clinician and how they would interpret that. So we do mark results like that as incorrect. The fourth example then at the bottom is just a report that's overly complex and confusing. And I think they're just copying something that a kit is produced into a report, which isn't very helpful. They've reported the DQA03 twice, first at the first field, but then narrowing it down to a potential 0302 or 03 allele. They've then reported alpha subunit DQ8, which again is potentially misleading because the presence of DQA103 without the DQB0302 or DQ8 has not been linked to celiac disease. So again, it's just quite a confusing report. So obviously we're very concerned about this level of unsatisfactory performance in the scheme. I think it does highlight that actually laboratories need to have some HLA expertise to be able to perform celiac disease testing. So to help, we are in the process of completing some celiac disease guidelines, and the working title so far is Laboratory Testing and Clinical Interpretation of HLA Genotyping Results in the Diagnosis of Celiac Disease. And this is a joint venture that we're hoping to get published in combination with BISHI, which is the UK professional body. So we are in the process of finishing preparation of these for publication. We're hoping that they'll be used as best practice guidelines for HLA testing reporting of celiac disease. They're very much aimed at non-H&I labs. So the paper covers like an introduction to HLA nomenclature, testing, HLA genes. We also include some suggested interpretive comments for clinical reports to try and make reporting of celiac disease more standardised, less complex. And our ultimate aim then, when these are published, is that we can use these guidelines to assess the interpretive comments. As I mentioned at the beginning of this scheme, we currently only assess the HLA results part. But what we often see is some labs get the HLA result part correct, but then put an incorrect interpretive comment. And it's unknown whether a clinician would bother looking at the HLA result or whether they'd just go straight and read the interpretive comment. So it is crucial that both elements are right to ensure correct patient care. So I'm just going to cover now a summary of all the scheme performance that we've had in 2020-21. So I've just represented here graphically some 5-year trends in unsatisfactory performance. As you can see, scheme 8, which is in the top left graph in yellow, has this high unsatisfactory performance rate. We're hoping that when the guidelines come out that this will start to come down. Some of the schemes this year have come down and are now quite low. So for example, the typing schemes, we've seen 0 errors in quite a few of those schemes, which is fantastic to see. Other schemes like the cross-matching schemes always have some level of unsatisfactory performance, usually under 20%, but this does vary a bit in some of the schemes as well. The antibody schemes generally, again, quite good, especially in the last couple of years. They've generally been under 10% labs that have unsatisfactory performance. So that's good to see as well. So finally, I just wanted to touch on something relevant to the UK labs, and this is around the UK pathology EQA governance. The RC Path is the organisation that helps oversee the EQA governance in the UK. But currently there is a review ongoing, and there is some work that's been started last year to look at developing a new governance framework for the oversight of EQA. There's 2 new boards been developed in the RC Path called the EQA Oversight Board and EQA Stakeholder Forum. And these groups have set up a couple of work streams to help deliver this new framework. So the first work stream is called Developing and Implementing a Governance and Assurance Framework, and I'm actually on that group. The second work stream is agreeing and implementing a consistent approach to identifying and responding to poor performance. And Amy is on that. And also Helena Lee, who used to be on our steering committee, she's also on this group. And these are going to be key work streams that are going to come up with some really good recommendations to help standardise EQA reporting and governance in the UK. So the current framework is that EQA providers obviously work to identify and report any persistent poor performing laboratories to National Quality Assurance Advisory panels. So as you're aware, a laboratory that fails a scheme 1 year, we refer to them as unsatisfactory performers or poor performers. If a lab then fails in more than one, in several schemes or the same scheme in subsequent years, or in 2 out of any 3 years, we would then start to call them persistent poor performers. Any persistent poor performers, we then report up to NQAP, which is the National Quality Assurance Advisory Panel, and we report to the Immunology Panel. The NQAP panels, which we have, Bishy has a representative on, Elizabeth Rowe is on that group, and she also comes along to our steering committee meetings as well. So these groups help to support EQA providers to deliver high quality EQA schemes by harmonising standards between different EQA providers. So while in H&I, we're the only UK-based provider of H&I EQA schemes, some disciplines, haematology, biochemistry, for example, there are a number of different providers within the UK. And we're working to try and standardise performance and criteria for what makes a poor performer and persistent poor performer, so that you don't get what we call scheme hopping occurring. So that is where labs think a scheme has easier criteria and they can pass it easier, so they go to the easier scheme. An important role of the NQAP panel is if we, as an EQA provider, identify any persistent poor performers, obviously we will, in the first instance, work with that laboratory to offer education and assistance, to try and find out the reasons why they've had those problems. But then we also report them to the NQAP panel, and the NQAP panel chair would also get in touch to offer advice and assistance in any way possible. The majority of issues that they get to that level get sorted out and are fine and get resolved, and then the labs generally have adequate performance after that. Unfortunately, though, if the lab fails to engage in any way or is stubborn and they don't want to engage in the process or change anything about the testing, then we would refer them up to the RCPath Quality Assurance in Pathology Committee. So this is a new revamped group. Some of you might be aware that it used to be called the Joint Working Group in Quality Assurance, but it's recently changed its name. And this is the group as part of the RCPath that has the overall oversight of performance in EQA in the UK. It's this group that would start to contact heads of departments and CEOs of organisations if they really felt there was an issue with EQA performance and the lab wasn't rectifying those problems. They would also start looking at reporting to UCAS, to CQC, or other relevant devolved bodies in the 4 nations. So this is where the performance issues get more serious, obviously. Luckily in H&I, we don't have many that go that far, although just a note of interest, for a celiac disease scheme this year, we did identify a persistent poor performer in the UK that had performance issues for the last few years. We engaged with them, we offered support and education, but ultimately they felt that they didn't have the expertise to be running the celiac disease scheme, so they voluntarily withdrew their services for celiac disease. So that was quite a good outcome in the end. So there is a lot more information about these groups and this work that's been undertaken on the RCPath website. I think the 3 groups will stay, the EQA providers, obviously, the NQAP panels and the QAPC, they're going to stay, but this whole review is going to look at around the documentation, the governance, the accountability, so the whole system can be a bit more streamlined. There we are, so that's all my slides done, so I'll be happy to take any questions.
Okay, Hi Deb, thanks for that presentation. You have a couple of questions in the Q&A box, so I'm just going to present those to you. If an organisation reports an issue with a specific kit, is this information given out to other participants?
I don't think we've had that situation yet, to be honest. So what we would do, it depends what kind of risk we thought was associated with that. We could definitely send it out anonymously. What we have done in the past, again, which is very successful, we do, as we've gone through this talk today, hopefully you've seen that we do a lot of method information and we do review kits performance and different method performance. We have reported kit manufacturers to the MHRA before, and we will do that. So that would probably be our first point of call if it was confirmed that it was a kit issue. What often we find is that they think it's a kit issue, but when they contact the manufacturer and get more information, they actually find out that it's the way the lab's using that kit rather than the kit per se. So the example that I have where we reported to the MHRA, again, it was a celiac disease kit actually, and we had a number of labs using that kit and they were all reporting in a very strange way and kept making interpretative errors. So that was interpreting the kit, sorry, that was, and how they reported to us then. When we reviewed, one of the labs sent us the kit insert for us to look at the advice they were giving, and actually we felt it was inappropriate and misleading, the advice that the kit was giving on how to report for celiac disease. So we contacted the kit manufacturer in the first instance, and we didn't receive a response. We then reported them to the MHRA, and who then contacted the kit manufacturer directly, who then quite quickly got in contact with us. We obviously had a bit of dialogue with them to talk about how they could improve their kits, and I'm pleased to say the outcome on this occasion was really good. We did get them to change their kit and they have now modified the kit insert, so that's really good.
Excellent. So another question from the Q&A. Why do disease association schemes require 100% consensus for satisfactory performance, whereas HLA typing, so for instance the 4A1 scheme, only require 90%? It could be considered that the clinical implication of an incorrect HLA type may be greater than in a disease association.
Yes, I don't disagree. We follow the FE-EPT rules for EQA providers, and that is the current levels that they use. I suppose the only reason I can think that it was set at 100% for disease and 90 for HLA typing is generally in our transplant patients, we would type everyone twice. So you've got that added safety net there. Whereas obviously for the disease association schemes, you're only typing or testing the patient once. So sometimes, so I could argue that that's more crucial because you've only got one opportunity to get it right.
Mm-hmm. Excellent. So we've got another question in the Q&A. Someone's just asking if we can confirm that in scheme 4A2, assessment at the second field, reporting null alleles with polymorphisms outside of the exons named, e.g. HLA DQB1 02 163 null, which is an exon 1 polymorphism, is that allowed?
Yes. So although we say for scheme 4A2, you have to remove as a minimum ambiguities in exons 2 and 3 for class 1 or exon 2 for class 2. Obviously, if the allele is a happens to be a rare allele that's you know, like this example here, that would be, if that was a correct result, we would expect that to be either included in the string or to be the only allele reported. Does that answer the question, Amy? Sorry, let me open the chat. I
think so.
So if the polymorphism is outside exons 2 and 3 or exons 2, then yes, it is allowed to be reported even if it's a null allele. We obviously recommend the FE standards where null alleles should be excluded, but we wouldn't penalise anyone for that, because we are aware a number of labs still use serology to rule out null alleles, and unfortunately we can't provide enough material to allow laboratories to do serological typing. So you won't be penalised for reporting a null per se, although for in the clinical situation we would expect you to rule out null alleles.
Okay, great. And the final question in the Q&A asks, do we know how many H&I labs are registered for the HFE schemes? I don't know.
I would say Amy or Geraint's probably better.
I don't know that off the top of my head, but I'm sure Geraint will answer that in the chat for you.
Yeah, there are a few, not loads, but there are a few still doing it, I think.
Yeah. Deb, I just wanted to sort of ask you a couple of questions as well. Yeah. So throughout your talk, it was sort of really evident that sample mix-ups are still a common occurrence. How do you think labs can tackle this?
Good question.
I know, a bit mean.
Evil question. They need to look at the procedures. You know, there's loads of things you can do. I'm a big fan of root cause analysis, the 5 whys. So if you have a sample mix-up, you need to look at your procedures. You need to look at what's going on. Other contributing factors is where you're doing your testing most productive to you know, are you by a door where you're constantly getting interrupted? You know, is your process lean, and in that, does your process flow nicely, or are you going backwards and forwards on yourself a lot? So there's a potential for mix-ups there. Yeah, it's really just about using your root cause analysis tools, I think, and incident investigations. When you get a sample mix-up, don't just go, oh, sample mix-ups happen. Really investigate what happened, why, and then change your procedures accordingly.
So do you think that training for staff in performing a proper root cause analysis would be a beneficial part of training? Yes,
definitely. And that is something that I've been quite keen on. For those of you that may have attended our participant meeting a few years ago in Birmingham, we actually had a speaker on root cause and investigation and incident investigation. Unfortunately, it's one of those skills that gets lost, I think, in scientists. We spend a lot of time training our scientists to do the laboratory work, the scientific and the clinical understanding, but not so much in the quality aspects around incident investigation, root cause analysis. So I think it is a skill that often people just have to pick up as they go along, and you don't necessarily receive any formal training. So yeah, training in those skills, I think, to critically look at what you're doing and why, are really important.
Mm-hmm. And along the theme of skills, in scheme 4A1 and 4A1I in particularly, do you think we should be concerned by the number of incorrect uses of nomenclature?
Yes, I do. And I don't know whether, again, as I think I mentioned a bit in my talk, I think a lot of labs now rely on computer systems that might translate a HLA type for them into a different format. And I think some of that skill is potentially being lost. I mean, when I was training, I was very much drilled into me, my broads and splits and my associations. I don't know whether that happens as much because people don't see the types as much as they used to and manually deal with them. I think it is concerning, as I said, you know, at the minute in the UK, we still report our HLA types to ODT. A lot of labs do that manually. And you need to be able to interpret a HLA type, molecular type into specificity to assess antibodies as well. So that's really important. If you get the wrong split of DQ3, for example, and the patient has that antibody and you miss it, then that's obviously quite crucial. So there are lots of situations I think it's a really good skill to still have. As I mentioned, I think a lot of labs would have manual procedures as a backup in case of business continuity. So again, suddenly if you have to go to reporting, I don't know, 20, 30 HLA types a week manually, instead of using a system, you need to ensure that those skills still exist for that reason.
Mm-hmm. I agree. Okay, I can't see any more questions in the Q&A, so unless anyone wants to slip a last one in there quickly, I think we'll draw this session to a close.